Hello friends, welcome to PW MedED. I'm your faculty, Dr. Shonali Chandra. So yesterday we were taking up the Obs Gynae session, FMGE Accelerate, and we are going to continue further with our discussion today. All right, so we're going to take up more MCQs. Today's lecture is going to be from 5 to 7 o'clock, and hopefully we can finish as many questions as possible. So good evening, Mohit. Yes, Lakshman. Good evening. So let's start. All right, without wasting any further time, and let's just see where we were yesterday. Good evening, Fatehpuria. All right. So now I have this question for you here. Hello, Jitendra. Identify the type of placenta previa as shown in this image. Yes. So you can see in this image that the placenta is in the lower segment, right? You can also see that the placenta is somewhere near the internal os, right? But it is just at the margins of the internal os, right? So this type of placenta previa is called as marginal placenta previa, and that is type 2. So type 1 is the low lying, which is in the lower segment, but it is not touching the internal os. Type 2 is marginal, that is just touching the internal os. Type 3 is partially covering the internal os, partially covering the internal os. And type 4 is total or complete placenta previa, right? Totally or completely covering the internal os, right? So in this image, this is a type 2, that is marginal placenta previa, right, Jitendra? Okay, so also please remember one more thing here. This type 1, type 2, type 3, type 4, these are the older classifications, but again they're asked in your MCQs in exams. But also remember what is the definition of low-lying placenta. You see, low-lying placenta means that the placental edge is within 2 centimeters of the internal os. That's a very important MCQ pointer, okay? Low-lying placenta will be placental edge within 2 centimeter of internal os. So it will include the marginal also. Okay, marginal will also be included as a low-lying placenta only, as long as it is within 2 centimeters of internal os. And the placenta previa, that is the type 3, type 4, they are the ones that are partially covering or totally covering internal os, right? So you need to remember this definition of low-lying placenta, right? Whatever be the situation, whether it is a low-lying placenta or whether it is a placenta previa that is partially or totally covering the internal os, there is no vaginal delivery. Delivery is always by cesarean section, remember that. Delivery is always by cesarean section, please remember that. Fatehpuria, the PDF after the lecture will be shared in the Telegram group. The link of the Telegram group is going to be there in the description box, okay? Now, next question. A patient presented with bleeding per vaginum, regular uterine contractions, and tense tender abdomen on palpation. Her blood pressure is 150 by 100 mmHg. Cervical dilatation is 5 centimeter, and full effacement is there, right? Fetal heart rate is 144. That's fine with adequate beat-to-beat variability. What is the likely diagnosis? Right, so she has come with antepartum hemorrhage. Okay, she has come with antepartum hemorrhage. Actually, in the question, there's no gestational age, but let's just assume that is at term pregnancy, or let's say whatever be the gestational age. Okay, so let's say term pregnancy. So patient presented with bleeding per vaginum, regular uterine contractions. So she is in labor also, but there is tense and tender abdomen and bleeding. So what is the diagnosis right now? See, there is a history of high BP as well, right? So all these findings go in favor of, very good. What are you answering? Placenta previa. Where is the information that it is placenta previa? Where is the information that the placenta is in the lower uterine segment? Have they told you in the question anywhere? No, they have not told you so far in the question, right? The fact that there is a history of high BP and the fact that there is tense and tender abdomen on palpation, right? And the fact that somebody actually did a PV and mentioned cervical dilatation 5 centimeter and full effacement. So on PV, there is no placenta anywhere, right? So this is a abruptio placentae. This is abruptio placentae. That's your diagnosis. Okay. So placental abruption is premature separation of a normally situated placenta, right? So what are your question pointers going to be whenever you have antepartum hemorrhage? Okay, if there is painless and causeless vaginal bleeding, so look at the history, what they're telling you. If there is absolutely no reason, no history of trauma or hypertension given, painless causeless vaginal bleeding, and look at the character of the bleeding. If it's a bright red bleeding, right, look at the abdominal examination findings also. If they tell you that the size of the uterus is equal to the period of gestation, right, the uterus is given to you as relaxed and the fetal heart rate is given as normal, it is more likely placenta previa. Okay, so in placenta previa, uterus size usually is going to be equal to the period of gestation, except for the fact, let's say for example that there is a malpresentation, there's a placenta previa with transverse lie, then the size of the uterus could be smaller than the period of gestation, right? The uterus is going to be relaxed, okay, until unless the woman has already gone into labor and she's getting contractions because she is in labor, and the fetal heart rate is going to be normal. So in this situation, it will be going more in favor of placenta previa. Okay, so these findings will go more in favor of placenta previa. On the other hand, if you have a history of trauma or hypertension given to you, these are high risk factors, right, for placental abruption. Sometimes they may say that there is altered dark colored bleeding, or bright red bleeding could also be there in case of revealed abruption. So in case it is revealed abruption, bright red frank bleeding will be there. If it is concealed abruption, then usually there is going to be altered dark colored bleeding. Okay, concealed versus revealed. However, most of the times, most commonly, it is a mixture of the two. Okay, part of the bleeding is concealed and part of the bleeding is revealed. Then look at the per abdomen finding. Okay, if the uterus size is more than the period of gestation, okay, that would go more in favor of placental abruption because of concealed hemorrhage. The uterus size could be more than the period of gestation, but it could also be same. It could also be same because of revealed abruption. Okay, if revealed abruption is there, no blood is collecting behind the placenta, then in that situation, uterus size could be same as the period of gestation as well. The important finding will be tense and tender uterus. This will clinch your diagnosis. Tense and tender uterus, or the uterine tone is going to be increased, because like we saw in the previous question, the woman is getting contractions also, right? So she could be getting contractions because she could be in labor already, and in between contractions the uterus will not completely relax. That is what it means to have increased uterine tone. That means in between contractions the uterus is not relaxing completely. The fetal heart rate could be normal, like we did in the previous question, we saw in the previous question also. However, there could be fetal distress, or the baby could already be dead, depending upon how much of the placenta has separated. Okay, if there is a severe degree of placental abruption, then bleeding is excessive also, and the fetal distress or even fetal death can happen. And this is maternal bleeding, so mother's life is also at risk because it is mother who is losing her blood. Okay, so in these situations, whenever you have a situation of antepartum hemorrhage, okay, look at history, character of bleeding, note the vitals also, because the woman could be in hemodynamic instability. Also keep that in mind. Do the per abdomen examination, and never ever do a per speculum or PV examination before knowing the location of the placenta. So the next step is going to be an ultrasound. If in the same scenario they had asked you the next step is going to be an ultrasound, right? So ultrasound will tell you the location of the placenta. So ultrasound will tell you, yes, it is a placenta previa. Okay, if it's a placenta previa case, then delivery has to be by cesarean section. So immediate cesarean section is done if any of these is present. Like for example, if it's a bleeding placenta previa, the woman is already in labor. Okay, the woman is already in labor, or she is already term. Okay, doesn't matter if there is no bleeding also. Okay, we will not wait for the patient to bleed. If she's already term, if she's already in labor, or she's unstable, or there is fetal distress, then we have to go for an immediate cesarean section, obviously. Now, if it's a dead fetus, if the baby is already dead, then there is no point waiting and waiting for the woman to bleed. Okay, because she is already a case of placenta previa. If and as when she will go into labor, she will definitely bleed, right? So if the baby is out of the equation, then there is no point waiting and watching, right? So if it's already dead baby, then also immediate cesarean section. Or let's say if the bleeding is continuing, it is not stopping, then also immediate cesarean section has to be done, and delivery for placenta previa is always by a cesarean section. Now, if on ultrasound the placenta is not low lying, okay, so ultrasound will only give you relevant information about the location of the placenta. So if you have this clinical information which goes in favor of placental abruption, then you do an ultrasound, and ultrasound tells you that the placenta is not low lying, then you make the diagnosis of placental abruption. Once you establish that the placenta is not low lying, meaning you have ruled out placenta previa, after that you can do a PS and a PV examination. Okay, so in your PV examination, after you have ruled out placenta previa, when we do a PV examination, we can find that the woman is already in labor also, like in the previous question where she was already 5 centimeter dilated, right? Then at that point in time, we can do ARM also. ARM can be done, artificial rupture of membranes can be done. We can find blood-stained liquor. And that will in turn confirm our diagnosis. Also. And doing ARM will also help to increase the uterine contraction so that the woman progresses in labor faster, because the management of placental abruption is going to be delivery. Okay, so the bleeding will stop only and only when the woman delivers and the placenta is out and the uterus contracts. So with placental abruption, the management is delivery and the management is vaginal delivery. Okay, so this is an MCQ in your exams. Please remember that. Hello us, right? So the management is going to be vaginal delivery. Okay, until unless there is an indication for a cesarean section. There is an obstetric indication for a cesarean section. Like for example, if there is fetal distress, then for the fetus's sake, obviously we will have to go for cesarean section. Or let's say there is any contraindication to vaginal delivery, like for example, if there is already inadequate pelvis, right, then of course one would want to go for a direct cesarean section, right? Please remember that sometimes patients with placental abruption can have DIC also. Okay, so if DIC is also present, then also delivery is vaginal only. But you'll have to go for correction of DIC as well. You have to go for correction of DIC by transfusing FFPs and cryoprecipitates, like you manage in your surgical patients as well. So all in all, do not forget, whatever be the management, don't forget resuscitation. Don't forget simultaneous resuscitation. Okay, don't forget that. That's a very, very important point to note. So in a bleeding patient, always focus on resuscitation. At the same time, management will depend on the situation at hand, whether it is placenta previa or whether it is placental abruption. So these are the important pointers regarding the clinical aspects of placenta previa and placental abruption that you should remember for your exams. Okay. Now let's have a look at the next question. There's a second gravida para 1 live 1 lady. She underwent cesarean section in previous pregnancy for fetal distress. So she is a history of previous cesarean section, right? This time she had an uneventful vaginal birth after cesarean section, but the placenta could not be removed completely. The cord snapped on traction, but the placenta did not deliver. She also started to bleed more profusely now. What is the reason for this? Yes, so the clue is there are two clues in the question. One clue is that she has a history of previous cesarean section. Second clue is that the placenta could not be removed completely. The placenta is not delivering. Instead, she is starting to bleed more profusely. Now she is having PPH. So what is the reason for this? Very good, Jitendra and Dilshad. It is a case of placenta accreta, right? So placenta accreta is a situation where the placenta, instead of attaching onto the decidua basalis, is penetrating deeper and attaching to the myometrium, right? So the plane of placental separation is not there. right? So what will happen, the placenta will either fail to separate completely, or the placenta will separate in bits and pieces. So the information in the question could be this also, that the placenta failed to separate in bits and pieces, or placenta separates in bits and pieces. That could also be the information. Okay. And it is because of this reason, when there is partial separation of placenta, that it leads to postpartum hemorrhage. Okay. The second situation where we have encountered placenta accreta is, so this is an acute presentation. Now, this is an acute presentation of placenta accreta. We did not know beforehand that it is a case of placenta accreta. The other situation could be that sometimes there is a retained placenta, and for retained placenta we are doing a manual removal of placenta. So question has been asked from you people in FMG in this manner also, that there is a case of retained placenta. Don't forget these important pointers. There is a case of retained placenta and manual removal of placenta was done, and there is no plane of cleavage found. No plane of cleavage found. It is a case of placenta accreta. The third situation where we encounter placenta accreta is, let's say that in this particular patient only, while vaginal delivery was being conducted, let's say for example that we apply too much of traction, okay, then it could lead to placental, that it could lead to uterine inversion also. Sometimes it could lead to uterine inversion during delivery of placenta. Sometimes it could lead to uterine inversion during delivery of placenta. Okay, so these sort of acute presentations of placenta accreta are described, and all three situations are important. Keep that in mind. Question can be around any of these three situations. Now, as you are saying, for diagnosis we could go for MRI. The patient is right there in front of you, right? She is delivering, or we may be doing a cesarean section, and during cesarean section we may not be able to separate the placenta. How will MRI help in this situation, right? We are already there, the diagnosis is made, we're not finding the plane of cleavage, it is placenta accreta, right? So at this point in time the diagnosis is very much clinical, right? We go ahead, manage the situation at hand, we manage the PPH, we manage the retained placenta situation, we manage the uterine inversion. Unfortunately, sometimes we may be able to separate the placenta completely, right? And at other point in time nothing works and the woman ends up with a hysterectomy eventually. So these are acute presentations where diagnosis by MRI has absolutely no role. Diagnosis is fairly evident clinically itself. Keep that in mind also, right? Now let's have a look at some important points you need to know about morbidly adherent placenta for your MCQs. See, the Nitabush layer, okay, the zone of fibrinoid necrosis which prevents deeper invasion of placenta, that layer is defective. So that's one important question pointer, keep in mind. The decidua basalis is either totally absent or partially absent in places, right? Keep that in mind. So there are three types, okay. Most commonly in 80% of cases it is placenta accreta, where it is just attached on the myometrium. Increta meaning it has gone deeper into the myometrium, and percreta meaning it has perforated the myometrium, right? Now the most common risk factor for placenta accreta or morbidly adherent placenta is a history of previous cesarean section. All right, so that is going to be a clue in your question, history of previous cesarean section. Also remember that any situation which leads to scarring in the uterus, that could be responsible. So there could be history of prior surgeries like myomectomy or multiple DNCs in the past, or there could be a history of let's say Asherman syndrome. So history of prior cesarean section is the most important, right? Then they ask you in which situation is maximum risk there. So there is history of prior cesarean section in a patient, plus this time now she has placenta previa and current pregnancy, then this situation is the maximum risk for having a morbidly adherent placenta. Now, in normal delivery, you have removed placenta post expulsion of fetus. How manual removal of placenta is different? Manual removal is done for retained placenta, where you put your hand inside the uterine cavity. The procedure is done under general anesthesia. Okay, for a situation where the placenta has failed to separate, so the placenta is still attached, we go along from the vagina, we go into the uterine cavity, and we have to manually separate the placenta. That is manual removal of placenta. So that is the difference. Okay, fine. All right. Now, you are saying, Mohit, that can placenta, after cesarean section, placenta previa occur, history of given just to create confusion. There is no confusion here. See, there is no confusion here. I mean, even if the history of previous, see, there is a history of previous cesarean section. Okay, so this previous cesarean section history makes the possibility of placenta accreta more likely. That is what it means here. Okay, Mohit? All right, because I didn't get what confusion you are here in this was a very straightforward question. There is absolutely no confusion in this question. Okay, no confusing thing here, right? Placenta could not be removed completely. History of previous cesarean section goes more in favor of a placenta accreta. Okay, now when you were asking about MRI for diagnosis. Okay, MRI for diagnosis. So the diagnosis of placenta accreta or morbidly adherent placenta in the antenatal situation, that means that the woman is pregnant. Let's say let's take an example that there is a woman, she's pregnant right now, she has a history of previous cesarean section, and she's placenta previa and current pregnancy, right? This information is given to you, this situation is given to you. Now you know that this is a maximum risk candidate for having a morbidly adherent placenta. So for antenatal diagnosis, okay, plain ultrasound is not going to be enough, right? So first we are going to go for ultrasound Doppler. Most of the times ultrasound Doppler is going to help make the diagnosis itself, but ultrasound Doppler can also be inconclusive. It may not be able to rule out morbidly adherent placenta. Then we are going to go for MRI. Okay, MRI is the best. MRI is the best, but MRI is expensive. So in clinical practice, we first go for ultrasound Doppler, and if required, we go for MRI. MRI is the best. It will give the most valuable information regarding whether or not is a morbidly adherent placenta or not. So that is there. That is for antenatal diagnosis. Okay. Now, next question. Maximum amount of amniotic fluid is seen at which gestational age? Yes. So among the options provided, maximum amount of amniotic fluid is seen at 32 weeks of gestation. So there is a range when the max amount of amniotic fluid maximum, the range is 32 to 34 weeks, right? So that is why I choose answer 32 weeks as the answer. 36 is not the correct answer. Okay, 36 weeks is not the correct answer. Okay, so keep that in mind. Now also please remember that around 12 weeks of gestation, the amount of amniotic fluid is only about 50 ml. Okay, it's maximum at around 32 to 34 weeks. Then at term, that is around 40 weeks, it is somewhere around 800 ml. And post term, okay, post term meaning somewhere at around 42 weeks, it's around 200 ml. Okay, so once the patient crosses term, the amount of amniotic fluid decreases, and by the time she reaches post term 42 weeks, the amount of amniotic fluid is only about 200 ml. Keep that in mind. So, what are the other important normal characteristics of amniotic fluid that you should remember for MCQ purposes? Okay, so the main content of amniotic fluid you all know is water. There is no explanation required here. 99% of the amniotic fluid is water, and this water is replaced every 3 hours. This water is replaced every 3 hours. Okay, the osmolality is about 260 milliosmol per liter. Basically, it is more dilute. It is more dilute or hypoosmolar. It is hypoosmolar, okay, than the plasma, than the maternal plasma as well as the fetal plasma. So that is what it means. The pH is 7.1 to 7.5, meaning that it is alkaline. If they ask you to pick one value, pick the one nearer to 7.1. Okay, so pH is 7.1 to 7.5. The color of the amniotic fluid is straw colored. Postterm, it is saffron colored. All these are important one-liner pointers. Okay, placental abruption, we just said it is a blood stained amniotic fluid, right? Intrauterine death, if there is a dead fetus retained inside the amniotic fluid, is tobacco juice like. In RH affected fetus, there is fetal hemolysis and bilirubin is released into the amniotic fluid. So amniotic fluid is golden yellow in color. Okay, and green colored amniotic fluid is seen in situations like when the amniotic fluid is meconium stained. Meconium is the first stool of the baby. So if the baby passes meconium in utero, it can lead to meconium stained liquor. Fetal distress can lead to green colored amniotic fluid, because fetal distress also leads to meconium passage by the fetus. That is why, right? And breach in labor, when there is a breach presentation delivering vaginally, then also it can lead to meconium passage, right? So basically green color is happening because of meconium passage by the fetus itself. Now let's have a look at the next question. A 22-year-old primee who is sure of her dates visits antenatal OPD at 20 weeks of period of gestation. Fundal height shows that the uterus is 16 weeks in size. Ultrasound shows decreased liquor. What is the probable cause? Yes, so this is a case of oligohydramnios. This is a case of oligohydramnios, right? What is the probable cause? You don't even need to look at other options, you know. There's just one option that fits. Okay, doesn't matter if you don't know about the other options. Think about it. Think about it. Where is the amniotic fluid coming from? Once you know that information, you'll realize that the main contributor of amniotic fluid is the fetal urine, right? So if there is renal agenesis in the fetus cannot form urine. It is going to lead to oligohydramnios. So renal agenesis is going to be your answer here. Okay, right? Got it? Yes. All right. So Potter's syndrome, you are saying. So Potter's, we're going to come to Potter's as well. First of all, let us highlight the important pointers. Okay, we're going to talk about all the points that you're mentioning one by one as well. So the main source of amniotic fluid, broadly, yes, please remember, it is the fetus itself. It is the fetus itself. Okay, so in the first 12 weeks, the amniotic fluid is coming from ultrafiltrate from maternal plasma, only till the first 12 weeks. Between 12 to 20 weeks, it is, you know, fluid that is transudating out across the fetal skin. So think of it like fetal sweating. Okay, 12 to 20 weeks transudation across fetal skin. So that is the fetus's contribution to amniotic fluid volume. And beyond 18 weeks onwards, you see the main contribution is from the fetal urine only, right? So fetus starts forming urine by 12 weeks of gestation. Okay, but the answer is different. Okay, fetal urine becomes the main contributor of amniotic fluid volume, or main main portion of amniotic fluid volume from 18 weeks onwards, but the fetus starts forming urine by 12 weeks itself. Okay, then fetal skin keratinization. Fetal skin keratinization occurs between 22 to 25 weeks of gestation. Okay, so that is why till 20 weeks transudation across fetal skin occurs. But once the fetal skin gets keratinized, this transudation across fetal skin cannot occur. Okay, so these are different question pointers you need to keep in mind also. All right, so what do we learn from this here? We learn from this here that the fetal urine is the main contributor of amniotic fluid, right? So any situation where the fetus cannot form urine, okay, or the fetus forms urine but there is some renal abnormality because of which the urine is not coming out, right? So that will lead to oligohydramnios, right? And also please remember that the fetus also swallows amniotic fluid. Okay, right? So on the one hand there is fetal urine. Okay, fetal urine that is adding to amniotic fluid volume. Okay, fetal urine is adding to amniotic fluid volume. That's why I make a plus sign. Okay, on the other hand, the fetus also swallows. Fetal swallows amniotic fluid also. So that takes away from the amniotic fluid volume. That's why, you know, a constant amniotic fluid volume is maintained. Otherwise, the fetus will keep producing urine on a daily basis, and the amniotic fluid volume will keep increasing, but it is maintained at a normal value, isn't it? Right? So the fetus produces about, you know, 1000 ml of urine per day. 1000 ml of urine per day is produced at term. That's a lot of urine. Fetus swallows about 750 ml of amniotic fluid per day. Swallows about 750 ml of amniotic fluid per day. So whatever fetal swallows, okay, that is going to be absorbed by the fetus gut also. That is going to be absorbed by the fetal gut as well. Right? So if you understand these two basic pointers, you can understand that if there is a situation, for example, let's say there is an abnormality in the fetus where the fetus can't swallow. Think of it like fetal vomiting. There is some abnormality by which the fetus is vomiting, regurgitating, whatever it is. One is it can't swallow only. The other thing is fetus swallows but then vomits it out, regurgitates it out. That will lead to, what will that lead to? If this is the situation, if these are the kind of abnormalities that the fetus is having, if the fetus can't swallow, it will lead to, if this is not happening, it will lead to polyhydramnios. It will lead to polyhydramnios. Okay, if fetus can't form urine or the urine doesn't come out, it will lead to oligohydramnios. As simple as that. Okay, so now let's have a look at the normal values, right? So direct questions on normal values also. So amniotic fluid volume is measured on ultrasound. This is on ultrasound. On ultrasound, we see the amniotic fluid index, or we can see the measurement of the SDP. SDP stands for single deepest pocket, and AFI stands for amniotic fluid index. Okay, right? So normal amniotic fluid index is 5 to 25 centimeter, or a single deepest pocket measures 2 to 8 centimeter. If the AFI is more than 25 or single deepest pocket is more than 8, it's polyhydramnios. In absolute amounts, if the amniotic fluid volume is more than 2000 ml, we call it as poly, but we are not measuring the absolute amount in clinical practice. So AFI less than 5, or a single deepest pocket less than 2 centimeter, that's oligo, or the absolute amount is less than 200 ml, we call it as oligohydramnios, right? So now if you look at the causes, now let's have a look at the causes. So if you have polyhydramnios, the most common cause is actually idiopathic. Most of the time no cause is identified. Okay, then there can be multiple pregnancy. Makes sense. What is there to mug up? If there are two fetuses, both fetus contribute to the urine output, and then it leads to polyhydramnios. Now fetal anomalies where the fetus can't swallow. So you said S, tracheoesophageal fistula, very good, but let's think about the common things first, right? So fetal anomalies, which fetal anomalies? Most commonly gastrointestinal tract anomalies, and then neural tube defects. Okay, then among the gastrointestinal tract anomalies, most common is cleft lip or cleft palate, because of which the fetus cannot swallow. Other anomalies like esophageal duodenal atresia, congenital diaphragmatic hernia, tracheoesophageal fistula, and neural tube defects, particularly like anencephaly as well. Then maternal diabetes. See, when there is maternal diabetes, then there is excess of glucose in the maternal bloodstream. So maternal hyperglycemia, that glucose crosses, reaches the fetus, fetal hyperglycemia, right? So what does that fetal hyperglycemia do? It leads to fetal polyuria. So that is the reason why there is polyhydramnios in maternal diabetes. It will happen if the mother is having uncontrolled blood sugar levels. Then fetal hydrops is also a cause of polyhydramnios, right? So broadly, these are your causes, the most important ones that you need to keep in mind. Okay, and if you look at the causes of oligohydramnios, there can be fetal anomalies. Like which set of fetal anomalies? Look at these are all renal anomalies. Yeah, these are all renal anomalies. Like there can be renal agenesis, multicystic dysplastic kidney, or infantile polycystic kidney disease, or posterior urethral valve, right? So if there's a posterior urethral valve because of which the urine cannot come out, then it will also lead to oligohydramnios. Or let's say that the membranes have already ruptured and all the amniotic fluid has leaked out. Postpartum is another cause, right? Growth restriction, IUGR, hypertensive disorders, they are also causes of oligohydramnios, right? So remember these causes. Now you were saying Potter syndrome. Some of you mentioned Potter syndrome. Now what is Potter syndrome? Potter syndrome is seen when there is a fetus with bilateral renal agenesis. Bilateral renal agenesis. What else is there in Potter syndrome? See, bilateral renal agenesis meaning that from 18 weeks onwards, this fetus is not going to produce urine. Okay, so there is absolutely going to be nil liquor, nil amniotic fluid from 18 weeks onwards. Now the baby is, that fetus is now inside the uterine cavity with absolutely no liquor, right? So obviously the baby is can't move inside and is, it's just kind of, the limbs are contractured like this, they stay like this, baby can't move, the face is pushed against the uterine wall, right? The lungs cannot expand properly of the fetus, so it can lead to other, sequence of events, right? So long duration of oligohydramnios in this situation with fetus with bilateral renal agenesis. What else is there? There is hypoplasia pulmonary hypoplasia plus compressed facies plus limb contractures, right? Limb contractures. Now this situation is called as Potter syndrome, right? Now the same sequence of events can happen because of any other cause of severe oligohydramnios early on in pregnancy. So if early on in pregnancy there is severe oligohydramnios, the same sequence of events can happen. But then if there is any other cause besides renal agenesis, then it is called as Potter sequence. So Potter sequence is the same sequence with some other cause. Okay, right? And Mohit, you're saying yes, ACE inhibitors, angiotensin receptor blockers, they can cause renal agenesis also, and that can lead to oligohydramnios. That is why these are teratogenic drugs which are contraindicated in pregnancy. Okay, so very good, Mohit. You corrected, connected the dots. Very good. Now, moving on, let's have a look at the next question. The term used to describe the process whereby the uterus comes back to non-pregnant state after delivery is called as what? Right? So the term used to describe the process by which the uterus comes back to non-pregnant state after delivery is called as what? The process is called as involution. See, let's clarify these terms. Okay, puerperium is the time period. Puerperium is the time period during which all the pregnancy related changes, okay, all the physiological and maternal adaptations that happen during the 9 months of pregnancy, those changes come back to the non-pregnant state. So the time period is called as puerperium. Okay, so time period during which the physiological changes of pregnancy come back to normal or non-pregnant state, that time period is called as puerperium, and the duration of puerperium is 6 weeks. Okay, involution is the process, it's a repair process. Okay, involution is a repair process by which the reproductive tract organs come back to the non-pregnant state. So that is called as involution. Remember these differences. Okay, and there is also fourth trimester. Don't get confused. Fourth trimester refers to 12 weeks postpartum. Okay, refers to a time period from delivery to 12 weeks postpartum. That is called as the fourth trimester. During this fourth trimester, the 6 weeks is the puerperium that takes place. Okay, so fourth trimester they have just mentioned because after delivery we should ensure that we see the woman at least at 12 weeks postpartum. So that is the fourth trimester, so that the care of the woman after delivery is extended till 12 weeks postpartum. That is the reason they have defined a fourth trimester. So don't get confused in these three terms. Okay, they are different. Now, the other important pointers that you should remember here is, again, after from Puerperium also they ask you certain very important one-liner questions, and they have asked you this in recent MCQs as well. So I have clubbed them all together for quick revision. What is the level of fundus immediately after delivery? Yes. What is the level of fundus immediately after delivery? Immediately after delivery, the level of fundus is just below the umbilicus. Just below the umbilicus. Okay, just below the umbilicus. It stays at that level for first 24 hours. After 24 hours, it starts decreasing at a rate of about 1 to 1.25 centimeter per day. Okay, so this 1.25 centimeter per day is roughly about 1 finger breadth per day. Okay, 1 finger breadth per day roughly. So remember these important pointers as well, right? Now, how much time does it take for the uterus to become a pelvic organ? So the fundal height is decreasing over time. Uterus will become a pelvic organ by 2 weeks postpartum. Okay, and if they ask you complete involution of the uterus, okay, if they ask you uterus becomes a pelvic organ by, answer is 2 weeks. If they ask you complete involution of the uterus, or they ask you complete involution of the placental side, any of these, if they ask you, the answer is full 6 weeks. Okay, it takes 6 weeks, right? Now, during the involution of the uterus, what happens? What happens during involution of the uterus? The uterus is shrinking in size, and at the same time, what is happening? There is lochia discharge. What is this lochia? This lochia is blood mixed vaginal discharge, right? And there is this superficial layer of decidua which had remained behind. It is also being shed off, right? So that layer of decidua is being shed off as well, and this together makes up the lochia. Then they ask you what is the sequence of the lochia. So the total duration of lochial discharge is somewhere around 2 to 3 weeks. Okay, somewhere around 2 to 3 weeks is the total duration of lochial discharge after delivery. The sequences lochia is rubra, serosa, and alba. So for the first 5 days, there is more of RBCs, so the lochia is red in color. For the next 5 days, there are more of WBCs and less of RBCs, so it is serous in color. And for the next 5 days, so first 5 days rubra, next 5 days serosa, and the last 5 days alba. Alba meaning white colored because of predominant of WBCs, right? So this is the sequence of lochial discharge, direct MCQ, remember that also. And they had asked you a question on after pains. Now, what are these after pains? So I told you that the uterus has to shrink in size, right? So that happens with uterine contractions as well, right? So these are after pains that a woman complains of. Cramping lower abdominal pain, that happens because of uterine contractions, and they become worse with infant suckling, right? So they are usually complained by multiparous women more often, and they become milder by day 3 postpartum. So woman just needs reassurance, and nothing really needs to be done for this. These are something very physiological. And the question they had asked you was, what is responsible for this after pains? Which hormone is responsible? So look at this, they worsen with infant suckling, right? So when infant suckles on the woman's breast, there's this oxytocin hormone that is released. The oxytocin hormone is the milk ejection hormone also. Remember, oxytocin hormone is the milk ejection hormone as well. Okay, so infant suckling promotes the release of oxytocin, and the same oxytocin causes uterine contractions also. So they had asked you what hormone is responsible for these after pains. Answer is oxytocin. This was a question in your recent FMGE examination as well, right? Now, let's have a look at the next question. This is slightly tricky. Now, the following are normal physiological changes during puerperium except. Yes, following are normal physiological, sorry, not except, there's no except in the question. Following are normal physiological changes during puerperium. So which is a normal physiological change? Which set of these 4 options is a normal physiological change? When you get questions like this, no, try to find out, try to eliminate. Let's say for example, why would there be weight gain? Why would there be weight gain during puerperium? In fact, during puerperium, the woman will lose weight. Don't you think so? She has delivered, the baby weight is out, right? The amniotic fluid weight is out, the placenta weight is out, and everything. And all that water retention that had happened, okay, that will also be relieved, right? So woman loses weight during the puerperium period. So there is absolutely not going to be weight gain until unless there is weight gain because of overeating or obesity or something, right? So puerperium per se does not lead to weight gain, so I'll just completely rule them out. Option number B and D, there is no weight gain that is happening. So I know that there is weight loss happening. Now Mohit, Dilshad and Fatehpuria and S, why would there be bradycardia? Why would there be bradycardia? Tell me. In pregnancy for the 9 months there is tachycardia, right? Now that tachycardia is going to persist for about, let's say, 24 to 48 hours after delivery. Chalo, theek hai, it did persist for 24 to 48 hours after delivery. After that it is going to settle down, but there is not going to be bradycardia, right? Why is there going to be bradycardia? Right? So as now you know why there is tachycardia, because during the 9 months of pregnancy there is tachycardia. So there is some time it will take to for the tachycardia to settle down and come back to the heart rate, to come back to the non-pregnant state, right? And then tachycardia during puerperium period or the immediate postpartum period could also be because of, let's say, pain can cause tachycardia. Maybe that is responsible, but at least bradycardia won't be there. At least bradycardia won't be there. That is absolutely not okay. So bradycardia not there. That's why I will rule this out. So let's see. Weight loss occurs, yes. Tachycardia, yes, because it will take some time for the raised heart rate to settle down. So it is, sometimes we can see tachycardia also. Diuresis, yes. All that water retention that happened during the 9 months of pregnancy, that will be eliminated because of diuresis that will take place, right? So these are the physiological changes. Okay, so does retention of urine happen? Yes, retention of urine also happen. Retention of urine can occur because of this during the course of delivery, when the head pushes against the pelvic floor, so the pelvic nerves are there in the pelvic floor, so there can be pelvic nerve compression, so bladder hypotonia can be there. So retention of urine, yes, of course, can be there. Retention of urine can be there because of bladder hypotonia. Okay, and ADH like action, beta ADH like action S तो सबसे last में I will think, but you are right. But then उसके लिए there has to be a history of some long term and long duration use of high dosages of oxytocin. That has to be there to lead to ADH like action of oxytocin, right? So more likely explanation would be bladder hypotonia if a woman is complaining of retention of urine. Other more likely reason could be, okay, now that you raise the question, retention of urine in the postpartum period. Okay, one we have already discussed, bladder hypotonia. Okay. Second thing that you want to keep in mind, so whenever there is a postpartum retention of urine postpartum, pain by itself, pain that is in the perineum, this could be because of local episiotomy given in that area, so that stitch line is paining. That is why always think about the possibility of genital hematoma, which can lead to retention of urine postpartum. So keep these important pointers in mind also, right? Okay, now other important pointers for MCQ questions. These are the important changes that we need to keep in mind around which questions can be asked, right? So the WBC count also increases after delivery. Keep that in mind. The blood volume will return to normal by 1 week. The cardiac output will return to normal by 10 days. And the fibrinogen levels which were raised during pregnancy, they will also remain elevated up till at least 2 weeks after delivery. After that they are going to settle down. Okay, so even in the postpartum period is also a hypercoagulable situation. That's why in the postpartum period we encourage women to quickly return and walk around to prevent the risk of thrombosis or deep venous thrombosis. So these are 4 important pointers for MCQs you should remember. Okay, now moving on. Next question. You're taking daily evening rounds of the maternity ward. A 23-year-old woman who has delivered her first child 2 days ago by normal vaginal delivery complains of bloody vaginal discharge. Okay, 23-year-old Normal vaginal delivery, she is having bloody vaginal discharge. She is afebrile, pulse rate is 88, post delivery HB 11, WBC count is 10,000, and the uterus is well contracted just below the umbilicus and non-tender. Pelvic examination also reveals a closed os and the vaginal fornices are non-tender. What is the most appropriate next step? So while you're figuring out the answer for this question, I'll take up SS doubt. Prolactin levels, why is it maximum in pregnancy, not after delivery? Okay, now prolactin levels. That's an interesting question. S, just give me some time. We'll take up this question and then we'll figure out the answer to that question. Okay, why is it maximum in pregnancy and not after delivery? All right. So what is the answer here? Jitendra D, oral antibiotics and reassurance. That is what Fatehpuria brothers want to do. Reassurance. See, why do you want to give oral antibiotics? I mean, where is the evidence of infection here? Where is the evidence of infection? She is afebrile. She does not have any fever. Pulse rate is settled. BP pulse rate is settled. Count is also fine, 10,000. Okay, count is also fine, 10,000. Right? Local examination, sweetish odor, bloody discharge. That's lochia. Sweetish odor, bloody discharge. That is simply lochia. Characteristic pungent smell it has. Per abdomen, uterus is well contracted just below the umbilicus, non-tender. All are normal findings, right? So at this moment, just reassure, right? There is no need for a urine analysis. There is no need to perform anything else, just reassurance, right? Because all of these are absolutely normal findings that are mentioned here in this question, right? So from puerperium, you should definitely know by what is normal changes in puerperium and what is abnormal, right? So these are all normal changes that have been described in this very question. So all that needs to be done right now is assurance. So what are your findings of puerperal sepsis, if that is the question? Okay, so let's just talk about puerperal sepsis also. So puerperal sepsis is basically infection of the upper genital tract. Upper genital tract meaning uterus and above. So upper genital tract infection as a consequence or as a result of delivery that happened, that is puerperal sepsis. So what is happening there? Metritis with pelvic cellulitis. Okay, so infection begins in the uterus. In the uterus, it begins in the endometrium, that it can spread outwards into the myometrium. It can spread even outwards into the peritoneal lining of the uterus. It can spread into the pelvic peritoneum and connective tissue also, leading to pelvic cellulitis depending upon how severe the infection is, right? So when you understand this one term, what is puerperal sepsis? It began in the uterus. Infection began in the uterus, metritis with pelvic cellulitis. The most important risk factor for puerperal sepsis is the route of delivery. Route of delivery. Okay, the incidence of puerperal sepsis is more post cesarean section rather than post vaginal delivery. That's an important point to note. And if they ask you what is the most common site of infection following a vaginal delivery, the most common site of infection is the placental site. Remember that, placental site, the raw placental site where the placenta was attached. Okay, and if they ask you most common site of infection following cesarean section, then during cesarean section we have given an incision on the uterus and then stitched it up, right? So it is the uterine incision site which is the most common site of infection following a cesarean section. So that is from where it begins, and then it can spread into the rest of the uterus and the causing maybe even pelvic cellulitis if the infection spreads further. Now most of these infections are polymicrobial. They are ascending infections, isn't it? They are ascending infections from the organisms that are present in the lower genital tract, right? So most infections are polymicrobial. In the polymicrobial infections also, most commonly they are anaerobes. Anaerobes most common as a group, and then aerobes, then aerobic bacteria. Okay, and if they ask you most common individual pathogen, then the answer is anaerobic streptococci, the peptostreptococci. So these are one-liner pointers that you should keep in mind regarding puerperal sepsis. Basic. Now the clinical presentation. Now, if the woman had presented with these symptoms, fever being the most important, pain abdomen, tender uterus, uterine subinvolution, right, means that the uterus is not shrinking in size as expected. Uterus subinvolution. That means, let's say, for example, you happen to see a woman at 6 weeks after delivery. And at 6 weeks after delivery, her uterus is still palpable per abdominally. By 6 weeks, the uterus should have become a pelvic organ, isn't it? It becomes a pelvic organ by 2 weeks after delivery. But I'm telling you that you're seeing a woman 6 weeks after delivery and you can still palpate the uterus per abdominally. That means there is uterine subinvolution. Foul smelling lochia would be there, or there can be, dirty vaginal discharge also. If these are the clinical presentation, then you think about puerperal sepsis, and then you think about, giving antibiotics as treatment. Okay, fine. So this is an important pointer you should know. All right. Now, let's have a look at the next question. A mother complains that her baby is not breastfeeding properly. On examination, the breasts are swollen and tender. What is the likely cause? Yes, mother complained. This is the only information that is given to you. This is an FMGE question. Mother complains that her baby is not breastfeeding properly. Look at the complaint of the woman. Okay, when you examine, breasts are swollen and tender. What is the likely cause? सीधे breast abscess, S, directly breast abscess, और कुछ सोचना ही नहीं, right? What is the likely cause? Sore nipple? The likely cause, S, very good. S is answering correctly. Now S has changed his answer. A, and no fever. Okay, so here the problem is that the baby is not feeding properly. Okay, so and both the breasts are swollen and tender. You see, they say breasts are swollen and tender. So if there is mastitis, that is infection and inflammation of the breast tissue, it is most likely going to be unilateral. And itis, inflammation, infection, will have fever. Okay, so most likely cause is going to be breast engorgement. That is going to be your answer here. So what is breast engorgement? Breast engorgement is a situation where the woman, and generally breast engorgement happens in the first 3 to 4 days of delivery. First 3 to 4 days of delivery, when the woman is still adjusting to feeding her baby. Okay, so what happens is that the woman is unable to feed properly, feeding techniques are not correct, right? So the baby is not feeding properly. Because of that reason, the breasts get filled with milk, they become engorged, they become swollen and tender. So that is what the woman complains of. Fever is very, very rare. Fever, mild fever can occur, fever rare, and if at all fever occurs, it will, definitely will never be more than 39 degrees Celsius. So fever very rarely occurs with breast engorgement. Mild can be there, right? So when the infant is having difficulty feeding, the breast gets engorged with milk. With engorged breast, feeding becomes painful for the mother. Baby also having difficulty in feeding again. So it's a cycle. Baby can't feed properly, breast get engorged. With engorged breast, woman will not be able to feed properly, and that is the issue. So the management is very, very simple. We can give her, analgesics for the pain. We'll ask her to manually express breast milk. Breast support is important, and breast milk, these breast pumps are also available in the market, which can be used. So the situation here is breast engorgement, right? So Mohit, you're rightly saying poor latching by the infant, that will lead to difficulty feeding and everything, right? Now, S, for your further questions, if there is mastitis, the history that you will look out for is high grade fever with chills. That is going to be the most important point in history. Mastitis, high grade fever with chills, and mastitis is usually going to present after 1 week. After 1 week, okay, not before that, right? And mastitis is usually going to be unilateral now, usually going to be unilateral. So there's going to be severe pain and a tender swelling on the affected breast. The overlying skin will also have features of all those features of infection and itis that you know of. The overlying skin is red, hot, tense and tender, right? So the most important feature, your diagnostic clinching point, is going to be high grade fever with chills. Keep that in mind, okay? Now, most common infective organism, if they ask you, what is the answer? Most common infective organism, right? What is the most common infective organism? It is Staph aureus. That is a direct MCQ. Then they ask you, where did the Staph aureus come from? The source of this organism. What is the source of this organism? Staph aureus. Where did it come from? The source of this organism is from the infant's nose and throat. Okay. And how did that organism enter the breast tissue? How did it organism enter the breast tissue? It enters the breast tissue through sore nipples or cracks. Through sore nipples or cracks. Okay. Now S. Mastitis and abscess, how to differentiate and what is the difference between the two? Bache, mastitis is simply infection and inflammation of breast tissue and parenchyma. What is an abscess? Abscess is pus collection. Abscess is pus collection, isn't it? So mastitis, let's say we identify mastitis. Okay, let's say we identify mastitis and we start treating. The treatment of mastitis is going to be antibiotics, isn't it? Treatment of mastitis is going to be antibiotics, and we want to give antibiotics which are effective against the most common organism. So mostly we are going to use dicloxacillin. Mostly empirically, if we are going to use dicloxacillin. Now let's say we have started the treatment with antibiotics and yet there is no improvement. Let's say the woman came back after 72 hours, right? And there is no improvement. Let's just assume that there was a case with mastitis and we have given the appropriate treatment, still there is no improvement. Then you think about breast abscess. One situation is that. Then you think about breast abscess. And also there will be a fluctuant swelling on the breast. There is going to be a fluctuant swelling on the breast. Abscess causes a fluctuant swelling. Sometimes this can be very difficult to appreciate on the loose breast tissue in the postpartum period. Fluctuancy, this you read about in surgery, Fluctuant swelling is an abscess, right? So fluctuant swelling on breast could be appreciated. If there is any doubt, we can always confirm with ultrasound, right? And we can make the diagnosis of breast abscess. Most situations, it will begin like this. A woman presented with mastitis, given appropriate treatment, but still there is no improvement in her situation. Then we think about the possibility of breast abscess. Okay. Now, let's have a look at the next question. A nurse posted in the labor room is advised to monitor the progress of labor using a partogram. After how much cervical dilatation should she start to plot the partogram? Yes. So, plotting the partogram begins at 4 centimeter, isn't it? So once the woman is at 4 centimeter dilatation, that is when the plotting of the partogram begins. Okay, this is in the modified WHO partogram. Okay, this is in the modified WHO partogram. Okay, in which there is no latent phase and we are plotting from 4 centimeter cervical dilatation. But if they ask you active phase of labor, please remember active phase of labor. Okay, according to the WHO latest recommendation, it is 5 centimeter dilatation. 5 centimeter dilatation according to WHO, and from the American guidelines on which all our standard textbooks are based, they say 6 centimeter dilatation. So if they ask you active phase of labor, you'll have to see what they are specifying. Sometimes they have asked specifically what the WHO says, then it is 4 centimeter dilatation. For the plotting of partogram, it begins at 4 centimeter, right? And the clinical questions that we ask are dependent on the American guidelines, which is 6 centimeters. So just remember this much should be enough. Okay. Now, before I move on to the next question, I'll take up the doubt that S had asked. Prolactin levels, why maximum in pregnancy and not after delivery? So just for this, see, this is the prolactin levels. Okay, these are the prolactin levels which continue to rise after delivery, right? So let's say this is the pregnancy period, this is she's pregnant, this is she's 40 weeks, this is she's term, let's say here, and here she is postpartum. Let's assume here she is postpartum. Okay, so now understand here that there is an increase in prolactin that we see happening throughout the pregnancy. Prolactin levels continue to rise. This is because of the estrogen stimulation. Okay, because of the estrogen stimulation, which promotes the release of prolactin. That is one thing. Now, after delivery, what happens? After delivery, what happens? The excess estrogen, all this excess estrogen was coming from the placenta. Na? These are the placental hormones, right? These are the placental hormones, right? Now, after delivery, what will happen? The placental hormones are going to decline. So, when the placental hormones are going to decline, then the prolactin levels are going to come down. Isn't it? The prolactin levels are going to decrease, and it will take some time for the prolactin levels to come back to non-pregnant levels, isn't it? So what are these? These are bouts of increased prolactin, which occur because of infant suckling, right? So infant suckling, whenever the woman is going to breastfeed, it is going to cause bouts of increased prolactin secretion also, right? But primarily, yes, after delivery, because the stimulus for prolactin secretion, constant increase in prolactin secretion is from the placental hormones, that isn't there. Okay, now let's come to the next question. All of the following are indications of instrumental vaginal delivery except, yes, indications of instrumental vaginal delivery, whether vacuum delivery, whether forceps delivery, whatever. So, when are we going to go for instrumental vaginal delivery? There are only few valid indications. The indication for instrument, why would you want to put instruments and deliver the baby? Because we are in a hurry. We are in a hurry in the second stage of labor. Okay, we want to expedite delivery, achieve delivery faster. So all in all, we want to cut short the second stage of labor. We want to cut short the second stage of labor. That is an indication for instrumental vaginal delivery. Why would I want to hurry in the second stage of labor? What's the rush? Let's say there is second stage fetal distress. Okay, then I would want to cut short the second stage of labor. Let's say the mother has a severe heart disease, and during the course of second stage, when she is bearing down, I see that she's having tachycardia, she's getting breathless, she probably will go into heart failure. Now I want her second stage to end quickly, right? So now I want to cut short the second stage of labor. I want to perform instrumental vaginal delivery, or the mother is so exhausted or so tired in the second stage that by my utmost efforts of counseling and reassurance, she is not bearing down, right? She is not bearing down. Second stage has arrested, so with second stage arrest, and I want to achieve a delivery, otherwise the baby would get compromised. So yes, then so all fits into one important thing whenever I want to cut short the second stage of labor. But if there is CPD, if there is CPD, if the head, there is cephalopelvic disproportion, right? If there is cephalopelvic disproportion and the head is having difficulty coming out from the vagina, and you want to apply instruments on that head and deliver it out of force, pull at it with force, you think that is going to achieve any purpose? right, there is a narrow door through which you want to enter. Okay, you are trying your best, nothing is helping, but then I am forcefully pulling you out. In that process I will injure you only. Don't you think so? Right, so cephalopelvic disproportion is actually a contraindication for instrumental vaginal delivery. Very, very important point to note. Very good. S, so with cephalopelvic disproportion, how much force you apply, आ भी सकता है बाहर, बट उसमें आने के चक्कर में फिर there will be maternal injury, there will be fetal injury, right? So we can't do that, right? So please remember, these are the valid indications for second stage for use of instrumental vaginal delivery. Always remember that the cervix should be fully dilated. Okay, the head should be engaged. Okay, it should preferably be a rotated head. Okay, the membranes should already be ruptured, otherwise how can we apply instrument? The station should be +2 and beyond. Station should be +2 and beyond. Okay, remember these important criteria. So these need to be fulfilled, otherwise we can't apply forceps, right? So cervix fully dilated, engaged head, rotated head, membranes ruptured, station +2 and beyond. And then also remember, last point is here, there should be no CPD and the pelvis should be adequate. Then only we apply instrumental vaginal delivery. Okay, then only instrumental vaginal delivery. Okay, now important points of difference between forceps versus vacuum. Okay, so forceps are instruments which are introduced into the vagina. Okay, so they are going to be more traumatic to the maternal tissues, the vaginal walls, the cervix and everything, right? So forceps cause more maternal injury, right? Whereas vacuum overall, because vacuum is applied on the baby's head and suction energy is applied on the baby's scalp, right? So more acute perinatal complications happen with vacuum as compared to forceps. Right, now also remember, I told you that the cervix should be fully dilated, right? The head should be rotated. Vacuum can be applied with incomplete cervical dilatation or even with a unrotated head. That doesn't mean that vacuum should be used. Okay, so if you are given a situation, look at these situations. If you're given a situation where there is fetal distress in the second stage and the cervix is not fully dilated, they tell you 6 centimeter dilated, they tell you station +1, they tell you station minus or whatever, don't answer vacuum at all. Okay, if these criteria are not met, it is cesarean section. Okay, please remember that also. Now, there are special situations where, if required, forceps can be used, like preterm. Okay, so let's say there is a preterm head. Okay, preterm head is there. Preterm scalp bones are softer. Okay, and preterm head is also much softer. Now you're applying vacuum here on those soft bones, and applying suction energy here, it will lead to more trauma. And the trauma that happens here is in the layers of the scalp. They have blood vessels, right? So those blood vessels can be torn because of that vacuum pressure, right? So preterm head, if at all we have to use instruments, vacuum can be used, right? Forceps can be used. If it's a mento anterior, you can't apply vacuum on the face. I mean, you can't apply vacuum on the face, right? So mento anterior position, if at all there is a need for instrument, forceps can be applied. After coming head of breech, yes, we have seen after coming head of breech, forceps can be applied. What are those forceps specially designed? Those specially designed forceps are the Piper's forceps. If there is a dead fetus, with this macerated head, you want to apply vacuum on a macerated head, I mean, it won't hold. So if at all any instrument on a dead fetus's head, it could be forceps, but it will not be vacuum. So remember these important points in forceps versus vacuum. Now let's see how questions are framed. See, the question would be framed like this: the following instrument should not be used in what? Think about it now. This is a forceps that we have shown, and this particular forceps is the Wrigley's forceps. This particular forceps is the Wrigley's forceps. These are smaller forceps. Okay, this is the handle, this is the shank. Okay, this is a smaller forceps. So these are the Wrigley's forceps. Even if these, if any forceps, what would be there? The question could be without an image. The question could be, forceps should not be used in what? Tell me now. Forceps should not be used in what? They can be used in after coming head of breech. Yes, they can be used. Twin delivery. Can forceps be used in twin delivery? Should not be used in bachche. Should not be used in what? Not be used. Not be used in what situation? After coming head of breech, they can be used. Okay. Twin delivery. Can we use? If the head is coming out, we can use. What is the problem? Okay, because at one point in time only one twin is going to come out now. So for that one particular twin, if required, forceps can be used. What is the problem? Post maturity, what is the problem? Doesn't matter. As long as the head is coming out and the criteria are met, it can be used. But if it's a big head, hydrocephalus, a big head, and it in itself means that there is CPD, na? Big head, hydrocephalus. So hydrocephalus, it will not be used, right? So you get the gist. You get the gist. So any options I can put here, but if you remember concept, you will arrive at the right answer, right? Now, Mohit, in macrosomic baby also. See, macrosomia simply means big baby, simply means that the estimated weight is more than 4 kg. It doesn't necessarily mean that there is CPD. 4.5, 4.5, 4.6, 4.2 kg babies deliver vaginally without any CPD. That's not a problem, right? And there are babies who are 3.5 kg, 3 kg, they also get stuck. Absolute thodi hai ye. Isn't it? It's not absolute, right? Okay, so CPD is a contraindication. Okay, Mohit. Now, also please remember, another MCQ they asked in your recent exam was about outlet forceps versus low forceps. Now, let me just give you the point here, okay? It is basically about forceps application. What did I tell you? That any instrument, be it vacuum or be it forceps, can only be applied if the head is way down. Na? If the head is way down into the pelvis, meaning +2 station and beyond. Okay, if we apply forceps at a point in time when the head is at +2 station, we call that application of forceps as low forceps application. Okay, fine. There is no high or mid cavity forceps, no high or mid cavity forceps application being done anymore. We don't do it. So we don't do any sort of high or mid cavity forceps application. Remember that. What is outlet forceps application? Outlet forceps application meaning that the head is right there. Okay, that means that the scalp is visible at the introitus or the head has reached the perineum. At that point in time when we apply forceps, it is called as outlet forceps application, right? Remember, so outlet forceps versus low forceps, it basically refers to type of forceps application. For outlet forceps, we generally use these Wrigley's forceps. Okay, Wrigley's forceps are used for outlet forceps application. That's why Wrigley's forceps are sometimes also called as outlet forceps. But outlet forceps technically means what is the application, at which point in time the forceps were applied. Okay, keep that in mind. Now let's have a look at the next question. Least risk of previous, this is from your recent FMG, least risk of previous cesarean scar rupture in a woman undergoing trial of labor after cesarean, that is TOLAC. Trial of labor after cesarean, short form TOLAC. Least risk of previous cesarean scar rupture in a woman undergoing TOLAC is with which situation? Least risk they are asking, least risk. So yesterday also we discussed history of previous 2 LSCS, very high risk situation. I don't go for vaginal delivery there because the risk of scar rupture is very, very high. So obviously this is not the answer. History of previous classical cesarean section. Obviously, I told you scar in the upper segment, very high risk, will rupture in subsequent pregnancy or with a trial of labor. So I don't go for vaginal delivery in this situation. Yesterday we discussed both A and B. Now C and D. S, history of macrosomia in previous pregnancy. Previous pregnancy. In previous pregnancy. अभी क्या है ना? History of macrosomia in previous pregnancy. How does it matter right now? If in this pregnancy she had macrosomia, or if in this pregnancy she had CPD, I would have understood. But they are saying history of macrosomia in previous pregnancy, right? Because they are saying previous pregnancy, that is why there is least risk. What about short interdelivery interval? Short interdelivery interval means that it is less than 18 months between the two deliveries. That means she delivered here, okay, she delivered here, and she became pregnant, and then she delivered here, meaning that she had a cesarean section here, okay, so cesarean section here. Then in the meanwhile she got pregnant, then she got finished 9 months of pregnancy also, and she is ready to deliver here. And between these two deliveries, okay, this one previous cesarean section and this one now, this duration is less than 18 months. So the time that is required for the proper healing of the uterine incision and scar, that time has not been properly there. So short interdelivery interval, less than 18 months. Okay, we have seen women with interdelivery interval of a year also. Yes, here had a cesarean section, gotten pregnant, and now here it's a year, less than 12 months also. So the shorter the interdelivery period interval, that means healing of the incision has not taken place properly. Obviously, the risk of scar rupture is going to increase. So the answer becomes C, right? So when you have a situation where there is a woman with previous cesarean section, the only list that I want you to really mug up to help you attempt MCQs in exams, right, is this list. I'll tell you why it will help. See, remember what are the absolute indications of repeat cesarean section. Absolute indications of repeat cesarean section. Okay, this is list you need to remember. Absolute indication of elective repeat cesarean section, meaning that trial of labor after cesarean is contraindicated. ठीक है, तो दो लिस्ट याद हो गई, right? Situations where trial of labor after cesarean is definitely not done. In these situations, agar we will not go for trial of labor after cesarean, so what will we do logically? Elective repeat cesarean section. So this is the list that you need to remember. If there is a history of prior classical or even a prior T-shaped incision. T-shaped incision meaning incision lower segment mein and then extending upwards into the upper uterine segment. So any situation where the incision had extended into the upper segment. History of previous scar rupture. History of previous 2 cesarean section. Obviously, these are situations where the risk of scar rupture is very, very high. Any contraindication to vaginal delivery. Any contraindication to vaginal delivery if there is inadequate pelvis, if there is already placenta previa, these are by themselves indications for cesarean section, na? Isn't it? Right? If there is CPD in current pregnancy, then I will absolutely not go for vaginal delivery with the previous cesarean section patient, but go for an elective repeat cesarean section, right? Woman does not want a trial of labor after cesarean section, or we are in a situation where the 24-hour OT facilities are not there, then in those situations we can't give a trial of labor after cesarean because it's very risky. The uterus can rupture, scar can rupture, complications can happen, emergency cesarean section can be needed to be performed at any point in time. So these are the indications where trial of labor is absolutely contraindicated and elective repeat cesarean section is done. All other complicated situations, You name it. If they are given in the option, just name all other associated complications. Like, let's say for example, like you said, macrosomia. Okay, macrosomia. Let's say macrosomia with previous cesarean section. Okay, or let's say previous cesarean section with post-term. Previous cesarean section post-term. Let's say previous cesarean section with breech. Let's say previous cesarean section with preeclampsia. Okay, let's say previous cesarean section with twins. Previous cesarean section with twins. Now these are situations where vaginal delivery can be done. Okay, trial of labor after cesarean can be done, but we usually don't prefer it. So these are situations where cesarean section is preferable. Cesarean section is preferable. है ना? तो क्वेश्चन आपसे पूछेंगे like this: where can vaginal delivery be done, or where can be vaginal delivery absolutely not be done in these situations, right? So remembering multiple lists can be a problem. That's why I tell you, remember this particular list. Situations where elective repeat cesarean section is always done. Situations where trial of labor after cesarean is definitely contraindicated. And there are other complicated situations where vaginal delivery is an option, but cesarean is generally preferable. So these are relative indications for cesarean section, right? These are relative indications for cesarean section, right? So in a woman who is post-term with a previous cesarean section, even induction of labor can be done. So yesterday we talked about the situations where induction of labor can't be done, right? So remember, one prior cesarean section, it was not an absolute contraindication to induction of labor also, right? Okay, so clear how if a question is formed in this situation, there is only one essential list to remember, and eliminate options that will help you come out at the come with the right answer. Okay, now next question. A 21-year-old primee is seen in the OPD for the first time at 8 months of pregnancy. She has pedal edema extending up to her knees. She has facial puffiness also. She looks pale. Her pulse rate is 96. BP is 150 by 100. Respiratory rate is 16. Chest is clear. I'm highlighting the abnormal findings. So edema is abnormal, BP is high, rest everything is fine. Uterus corresponds to 32 weeks in size, fetal heart rate is fine. All of the following are done except very good quick answer, start diuretic. It makes no sense to start diuretics. No? It makes no sense to start diuretics right now. She has high BP. Whenever there is high BP in pregnancy, you have to first check the urine protein. Right, check the urine protein. So you check the urine protein, yes, you send the investigations like CBC, LFT, KFT, you send for those investigations, very important. You start the diuretics, not at all, they are not required, and you are going to go for blood pressure control. That is, of course, you are going to do, right? So there is no sense in starting diuretics here at all, right? So look at this here, look at this chart here. We're going to quickly revise the hypertensive disorders in pregnancy. Okay, so whenever you find high BP here, okay, high BP here anytime beyond 20 weeks of, so this is where the woman got pregnant, this is 20 weeks, so anytime high BP found beyond 20 weeks of pregnancy, right? But the BP will come back to normal within 12 weeks postpartum. When you find high BP in this range, there are two possibilities. One is gestational hypertension. So in gestational hypertension, there will be no proteinuria. There will be no proteinuria and there will be no end organ changes. Okay, so this is what we want to see now when we see high BP in pregnancy. This is what we want to see. Is there proteinuria? Is there any end organ change? So what do you want to see for proteinuria? Oh, to check for urine protein, what can we do? We can check for the urine dipstick, isn't it? You can check for the urine dipstick in the OPD. Very simple, more than 1 plus, it will be positive, right? And we can check for 24-hour urine protein excretion. That has to be more than or equal to 300 milligram per day. That would be significant proteinuria. right? So, or there can be urine protein to creatinine ratio, more than or equal to 0.3, right? So this will be the definition for significant proteinuria, and you have to check for end organ changes. So that is why we were sending the CBC na. In CBC we'll see the hemoglobin, we'll see the hematocrit also, but what will be the end organ change? Platelet count low, thrombocytopenia, low platelet count, less than 1 lakh, right? In LFT, what will we see most importantly? Liver enzymes. Liver enzymes are raised 2 times the upper limit of normal. KFT you send. In that, what will you see? You will see the serum creatinine. So, raised serum creatinine more than 1.1 milligram per deciliter. That will be an end organ change. Or there can be other end organ changes like complaint of headache, blurring of vision, epigastric pain, right? So these symptoms could be there, cerebral edema could be there, pulmonary edema could be there. Think of a system and the finding is there. End organ change meaning any end organ change, okay? And think of an organ, it is there, okay? In the blood, CBC, liver LFT, kidney KFT you have to check, okay? And then lungs, pulmonary edema, brain, you can think about cerebral edema, then remember headache and blurring of vision, any system, okay? Any end organ change. Edema is a normal physiological finding. Yes, it could be normal physiological finding also, but if it's a pedal edema which is physiological, it is going to subside after rest, isn't it? It is usually mild, it does not extend all the way up to the knees, and facial puffiness is something that is not physiological, right? Okay, fine. So whenever I have this edema in pregnancy also, I will definitely look at the BP na. Pregnant woman में सिर्फ edema ही थोड़ी देखते हो. Pregnant women जब and pregnant woman one comes for an antenatal checkup, you also at each visit check her BP also na. So you won't have a situation where you'll have a woman with pedal edema and you will not check her BP, isn't it? Right? So your situation here, gestation hypertension, no proteinuria, no end organ changes. If we find a situation where there is proteinuria and or any end organ change any end organ change, we call it as preeclampsia. Right? So the moment there is proteinuria plus or meaning कि proteinuria could be absent, but there could be any end organ change, then also it is preeclampsia. So proteinuria is not essential or mandatory to make this diagnosis. Proteinuria and or any end organ change, it is preeclampsia. What is severe preeclampsia? Severe preeclampsia is when there is going to be blood pressure which is more than 160 by 10 mmHg, or there is any end organ change. Then we call it as severe preeclampsia. Okay, degree of proteinuria is not related to severity. Okay, keep that in mind also. There has to be any end organ change to call it as severe preeclampsia. And then finally there can be this situation. There can be a situation where a woman is hypertension before pregnancy, or she is hypertensive here before 20 weeks. Then in this situation, this is chronic hypertension in pregnancy. So she's already hypertensive before pregnancy, or hypertension has been diagnosed before 20 weeks of pregnancy. This is chronic hypertension. Even then we will check for urine protein. Even then we will check for end organ changes, right? Because chronic hypertensive patients can further develop preeclampsia. So the management does not change. Whenever you see high BP in pregnancy, you have to check for urine protein and check for end organ changes. Very, very important point to note. Now, one liner important point is, what is the drug of choice for hypertension in pregnancy? The drug of choice for hypertension in pregnancy is labetalol. Okay, oral labetalol, or in hypertensive crisis, we can use IV labetalol, but it is labetalol. Methyl dopa is a good drug, nifedipine, all these are first line drugs. Labetalol, methyl dopa, nifedipine, hydralazine, all are first line drugs. But if they specifically ask you drug of choice, it's labetalol. Drugs that are contraindicated, we just discussed this previously also. ARBs, ACE inhibitors, other beta blockers as well. Other beta blockers, that means like atenolol, metoprolol, these ones. Okay. Now, एंड ऑर्गन चेंज डैमेज प्री एक्लेम्शिया एंड सीवियर प्री एक्लेम्शिया दोनों में, हाँ नहीं तो क्या, वाई नॉट. पहले तो यू विल से इट इज प्री एक्लेम्शिया, फर्स्ट यू विल से इट इज प्री एक्लेम्शिया, isn't it? So you can have a situation where you will have high BP plus proteinuria, you will say it is preeclampsia. But if there is high BP plus proteinuria plus any end organ change, it will become severe preeclampsia. There is no moderate preeclampsia. It's either mild or it is severe. It's either mild, or it is severe. Okay, mild would mean that proteinuria is there, let's say, and end organ changes, no end organ changes are there. The moment the BP becomes persistently on the higher side, BP becomes difficult to control, BP is not getting control, it is remaining more than 160 by 110, or any end organ change appears, it is called as severe preeclampsia. Okay? Okay? Can severe preeclampsia be considered eclampsia? No. Eclampsia is when severe preeclampsia gets complicated with convulsions. That is severe, that is eclampsia. Okay, fine. Now, they ask you what is the drug of choice for eclampsia. What is the drug of choice for eclampsia? What is the drug of choice for eclampsia, they ask you? वैसे whenever you have a situation with eclampsia, let me also tell you here itself, whenever you have eclampsia, first focus on stabilization of the patient. Stabilization. Patient is having a convulsion. Patient is having a convulsion. Airway protection is very, very important. ABC, airway, breathing, circulation. Focus on stabilization. Then we will give magnesium sulfate, right? This is going to be neuroprotective, right? Magnesium sulfate has anticonvulsant action. It is going to prevent convulsions. Very, very important point. Okay, the convulsion that a woman has with eclampsia, that convulsion is a generalized tonic-clonic seizure. Okay, it is going to last for a minute or so, but once a convulsion happens, it can always happen again until unless we start magnesium sulfate. Okay, so magnesium sulfate, neuroprotective, anticonvulsant action. It has a central anticonvulsant action. Please remember, magnesium sulfate is not antihypertensive. So we will have to give other drugs for BP control. We'll have to give antihypertensive drugs separately, and we will have to deliver the woman, right? There is no conservative management at all, no conservative management at all once a woman has a convulsion. Doesn't matter what gestation she is, we have to deliver. Delivery can definitely be done by vaginal route. Okay, cesarean is done only for obstetric indications. So delivery, vaginal, cesarean section for obstetric indications. Okay, keep that in mind. So now when they ask you the drug of choice, the drug of choice is magnesium sulfate. Remember that. Okay, sometimes women who have eclampsia, they also have cerebral edema. Okay, cerebral edema, and so much cerebral edema that is there that they are comatose, because generally women will have a convulsion, then they will wake up after the convulsion is over. They'll be in that drowsy state, you know, drowsy, lethargic and all, maybe sometime delirium also, right? So they will be in this post-ictal phase, we call it. Okay, this is true for any person who's had a convulsion, will be in the post-ictal phase for some time, right? But if there is a situation where there is a woman with eclampsia with cerebral edema, which has been documented on a CT scan, and she is comatose, then we generally add mannitol also to the therapy. Mannitol for treatment of cerebral edema, that is also added. This was also an FMGE question, not recent but some time back. Okay, so keep that in mind. Now look at this. You were asking me mild, severe. Okay, look at this. Mannitol is a drug. It is used for treating cerebral edema. Now, mild preeclampsia, that means BP is also controlled. Okay, no end organ changes are there. BP is also controlled. No end organ changes are there. Basically, the mother and baby both are well. Sab theek hai na? Everything is fine. Is mild preeclampsia, BP भी control हो गया है, no end organ change, mother baby both well. Deliver after 37 completed weeks. Okay, the moment we have severe preeclampsia, very high BP, right, or there is any end organ change, admit, send investigation, stabilize the patient, control the BP, watch for signs and symptoms of impending eclampsia, and if it is less than 34 weeks, then we also start steroids. If it is less than 34 weeks, then we also start steroids for pulmonary maturity. If a woman with severe preeclampsia, she's already 34 weeks, then we are going to deliver the patient. Okay, severe preeclampsia already more than 34 weeks, then we are going to deliver the patient also. But we are also going to put in all these measures in place. We are also going to put all these measures in place also at the same time, है ना? So any patient with severe preeclampsia, इतना तो करोगे, you will do this much: admit, send investigation, stabilize, control BP, watch for signs and symptoms of impending eclampsia. Now, what are these signs and symptoms of impending eclampsia? If a woman starts having headache, convulsions, right, epigastric pain, convulsions नहीं, sorry, headache, blurring of vision, convulsion तो convulsion हो गया, headache, blurring of vision, epigastric pain, right? These are your signs and symptoms of impending eclampsia, meaning she can have a convulsion at any moment now, right? So keep them in mind. You will have to watch for these signs and symptoms, because the moment there are these signs and symptoms, we deliver. Look at this list. Remember this list. Remember this list. These are the situations where you are going to deliver whatever is the period of gestation. Eclampsia, HELP syndrome, signs and symptoms of impending eclampsia, placental abruption. We just discussed placental abruption. We have to deliver. If there is fetal distress, we have to deliver irrespective of period of gestation, right? Got it? So these are the situations where you deliver irrespective of period of gestation. Remember what is HELP syndrome? HELP syndrome is nothing but a mnemonic. HELP syndrome is hemolysis, okay, elevated liver enzymes. Remember that, elevated liver enzymes and your low platelets. When these three things happen together, occur together, it is called as HELP syndrome. Okay? Okay. Now, let's come to the next question. Okay. Now, all of the following drugs can be used for tocolysis in preterm labor except. So, which of the following drugs, which among the following drugs cannot be used in preterm labor? All of the following drugs can be used except, yes, the woman is already in preterm labor. So, break nahi bacche, Dilshad, we are going to wrap it up in another 15 minutes. Yeah. You have an INICET class also coming up from 8 o'clock onwards. So we're going to wrap it up in another 15 minutes. So all of the following drugs can be used for tocolysis except except all can be used except nifedipine has tocolytic action, calcium channel blocker, calcium ions responsible for smooth muscle contraction. Nifedipine, calcium channel blocker, has tocolytic action. Terbutaline, beta agonists, relaxes smooth muscles, has tocolytic action. Magnesium sulfate also has tocolytic action, but progesterone cannot stop a labor that has already started. Progesterone is not a tocolytic agent. Progesterone is used for prevention of preterm birth, in high risk women, not in all also, okay, in high risk pregnant women. Which are these high risk pregnant women? Women who have a short cervical length, incidentally diagnosed short cervical length, or who have a history of prior spontaneous preterm birth. Then progesterone has a role, right? Then progesterone have a role. So what are these tocolytic agents? So the agents we know of are nifedipine, right? They ask you questions on the side effects of these tocolytic agents. Okay, so let's see how questions are framed. Nifedipine is the most, see, none of these tocolytic agents now are absolutely safe. All of these tocolytic agents have some side effect or the other. That is why we use tocolysis only and only for 48 hours, if at all we have to use in a patient with preterm labor. Keep that in mind. So that is why they ask you questions on the important side effects. Okay, so if we have to choose, nifedipine is the one which we are using most commonly. Beta agonists, the most dangerous side effect that we have from beta agonist is pulmonary edema. They do ask you questions on side effects of beta agonists also. Now you can consider it a pharma question, you can consider it's an ops question, it could be an integrated question where a situation can be given that there is a woman in preterm labor and she's been given this drug. What complication could it result in? Right, so remember these complications like tachycardia, tremor, hyperglycemia, pulmonary edema. You read about them in pharma also. Indomethacin is a prostaglandin synthesis inhibitor, isn't it? It is an NSAID. It inhibits prostaglandin synthesis. So it is causing oligohydramnios as a side effect. If it is used before 32 weeks of gestation, it can also lead to premature closure of ductus arteriosus. That is why we don't prefer to use it. Now look here, I will tell you the way they asked questions. You see, indomethacin causes oligohydramnios as a side effect. Okay, so that is why we generally don't prefer to use it when we are going to go for tocolysis. We use the most common nifedipine that we use. Now also understand here that this side effect profile of indomethacin also has been used sometimes to treat women with polyhydramnios. Interesting, right? So polyhydramnios patients, you see, polyhydramnios, we should have discussed it there, but let us discuss it right now. Polyhydramnios will cause over distension of the woman's uterus. Okay, will cause again more compression upwards on the diaphragm of the mother, leading to more respiratory discomfort to the woman, isn't it? So much so that sometimes it can even lead to a situation where the woman is having respiratory distress maybe. And then in your exam they had asked this question that what to do, can anything be done for this polyhydramnios? So the drug that could be used is indomethacin could be used. But if I am going to use indomethacin and she is less than 32 weeks, it will lead to premature closure of ductus arteriosus. So that was the side effect, and they had asked a question on this, right? That indomethacin is being used for this situation. What is the potential side effect? And what else can be done in this situation? Other thing that can be done in this situation is a therapeutic amniocentesis. Remove the amniotic fluid, drain some of the amniotic fluid, slow drainage of about 500 ml of amniotic fluid. That can be done. That is what is done, but only under circumstances when polyhydramnios is causing excessive maternal symptoms like respiratory distress. Now, magnesium sulfate also has a tocolytic action, but long duration use of magnesium sulfate can cause bone thinning in the fetus. And magnesium sulfate is also something that we are not using as a tocolytic agent in clinical practice, because the dosages at which magnesium sulfate has tocolytic action, those are the very same dosages at which side effects are also more likely. So around 8 to 10 milli equivalent per liter. So magnesium sulfate generally not preferred. Then we have atosiban, which is oxytocin receptor antagonist. Remember, yes, this is drug atosiban. It is available in India also. Private practitioners, they are using it also. It is not available in government supply. Atosiban, oxytocin receptor antagonist. At least remember this much. There is very conflicting evidence regarding whether atosiban is good or not. Okay, very conflicting evidence. So let's not go into the details of those, but at least remember what are the drugs that have tocolytic action. This much you should definitely know. And then what else you should know regarding preterm labor? You should know how to make the diagnosis of preterm labor. So the diagnosis of preterm labor is made like any other labor, okay? There is regular uterine contractions with a cervical dilatation, at least of 2 centimeter or more than 2 centimeter on initial presentation. Heck, this is how you diagnose labor anyways also. Regular uterine contractions with cervical change. Which change is most important? Dilatation more than or equal to 2 centimeter. If yes, then this is established preterm labor. If yes, this is established preterm labor. Diagnosis is confirmed, no problem. If no, that means she has come with pain abdomen. She may have some contractions on something, but the cervical dilatation is not there. Cervical dilatation is not there, or it is less than 2 centimeter. Then what do we do in that situation? This is what we call as threatened preterm labor. We will call it as threatened preterm labor, and the most logical thing to do would be to admit and observe for some time. Admit and observe whether there is any progress in the uterine contractions, whether there is any progress in cervical dilatation. Okay, so that is what is done in clinical practice. That is what is done. And are there any tests that we could do in a situation where we are not able to make a clear-cut clinical diagnosis? Then there are tests that are mentioned, but we are generally not doing them in clinical practice, right? So the marker for diagnosis of preterm labor and the marker for diagnosis would be needed here. Let's say here, when the cervical dilatation is not there, it is a threatened preterm labor. Ideally, yes, I would admit and observe, but if at all there is a marker for diagnosis of preterm labor, I could use that marker. So what is that marker for diagnosis of preterm labor? That is fetal fibronectin. Remember this, fetal fibronectin in these cervicovaginal secretions. Fetal fibronectin in cervicovaginal secretions. Okay, so we can test the cervicovaginal secretions for presence of fetal fibronectin between 24 to 34 weeks. Only then it is useful, right? If they ask you what is the marker for prediction, see, look at the change in language. Prediction of increased risk of preterm labor in a woman with previous history of spontaneous preterm labor. Look at the change in the situation. Question number 1, they are asking marker for diagnosis of preterm labor. Second point, they are asking you prediction. Can you predict the risk of preterm labor in a woman maybe who has had history of prior spontaneous preterm labor? Then cervical length on transvaginal sonography. Remember that we discussed that yesterday also in cervical incompetence. So if it is less than 25 mm before 24 weeks, it is predictive of increased risk of preterm labor. So these are important one-liner pointers again for MCQs. You should remember that as well. And now finally, let's talk about the steroids also. For whenever a woman goes into pulmonary preterm labor, we always give steroids for pulmonary maturity of the fetus. We always give steroids for pulmonary maturity of the fetus, right? So what are these steroids? What is the drug of choice? Yes, what is the drug of choice? Anybody? Very, very important. They have asked you questions on this. When we give steroids for pulmonary maturity of the fetus, what is the drug of choice? We have two. We have dexamethasone, we have betamethasone. Okay, both are equally good. Both are equally good. Both drug, dexa as well as betamethasone, both are equally efficacious. Both are equally efficacious for prevention of respiratory distress syndrome in the newborn. The drug of choice, if you have to pick one, you will pick dexamethasone. Okay, if you have to pick one, you will have to pick dexamethasone. Because it is available free of cost in the government supply. We have been consistently using this, so we have a lot of Indian data also supporting that it is very, very efficacious. And for us, dexamethasone is the drug of choice. Okay, earlier textbooks used to write beta is slightly better, this and that. Newer textbook, now they are saying that they are equally efficacious, and we have always been using dexamethasone. So drug of choice for us is dexamethasone. They ask you dose also, 6 milligram intramuscularly every 12 hours for 4 dosage. This is so commonly used now. You have to remember this dose. They have asked you questions on that. 6 milligrams IM every 12 hours for 4 doses. And the dose for betamethasone is 12 milligram IM 24 hours apart for 2 doses. For 2 doses. Okay. So remember this. And also remember that steroids for pulmonary maturity of the fetus will be given in any situation where the woman is going into preterm labor before 34 weeks, or we are inducing maybe preterm labor. Now we are just say, even in preeclampsia patients, na, severe preeclampsia who were less than 34 weeks, we were giving, right? So in situations where delivery is expected to happen, as we don't need to mug up. In situations where delivery is expected to happen before 34 weeks, we will give steroids, right? So if less than 34 weeks, we will definitely give steroids. We will definitely give steroids. Remember that. And now latest they are saying that if she is between 34 to 37 weeks, we consider giving steroids. Okay, we consider giving steroids. So that is just the new change that is there. However, it is certain that before 34 weeks we should definitely give. If between 34 to 37 weeks, we consider steroids case to case basis. Okay, keep that in mind. All right. Now you are asking me what are the important topics for FMGE exam. Okay, so let us also note down, because we are wrapping up, the important topics for your FMGE exam. All the basic topics. I have seen the trend over the last 5 years. Okay, they are more and more asking you about the basic topics. Okay, basic topics like, let's say for example, menstrual cycle. Begin in gynae with menstrual cycle. I mean, these are the foundation chapters. They will anyways you will do. Puberty and disorders of puberty. Puberty and disorders of puberty, important topic. Okay, then abnormal bleeding. Abnormal bleeding in reproductive age group. Okay, broadly I'm telling you because your exams are very near. Abnormal bleeding in reproductive age group, meaning that it will cover what it will cover. Once, before you start reading about abnormal bleeding in reproductive age group, you'll also have to know what are the patterns of abnormal bleeding, है ना? What are the patterns? Definition, basic. What are the basic patterns of abnormal bleeding, right? Then in this broad heading, you will cover fibroids, you will cover adenomyosis, you will cover endometrial hyperplasias and polyps. Okay, in this broadly you are going to cover also anovulation causes. You're going to cover PCOS. This is what you need to read up in detail. Okay, they are constantly asking you questions more and more about hormones and hormone action and everything, right? So you do need to know about hyperprolactinemia, excess prolactin. At least know this much. Read about prolactin and read about excess prolactin. This is must. Okay, ये इतना. This is we are covering gynae. Then you have to talk about infertility. Infertility is an important topic, right? Basic about infertility, meaning what are the basic tests in an infertile couple? Tests for ovulation, tests for tubal patency, right? So basic workup of infertile couple. Basic workup of infertile couple. Okay, and basic treatment options. Okay, when I talk about basic treatment options, meaning like basically about drugs used for ovulation induction commonly, intrauterine insemination, where it is used, IVF, where it is used. So basic pointers there. And when I say basic workup of infertile couple, I want to tell you about, I want to say that they will ask you about female infertility as well as male infertility, right? Now I have discussed all of this. I have discussed, let me also tell you, if you're thinking that I have not discussed this, I have discussed all of this in the NEET PG discussion that is also free on YouTube. Okay, there was this session on YouTube in which we were discussing NEET PG previous year questions, and this all has been discussed. And Jitendra, if I'm going to teach all of these topics, then who is going to teach you the other obstetric important topics? They are also equally important. So this is about gynae. I have taken a session on gynae cancers as well. Okay, I have taken a session on gynae cancers as well. All right, this is also free on YouTube in the PW MedED app channel only, right? So this is there free on YouTube, right? You can find it there. And if you look at all the obstetrics that we have done, that is all very important. Your antepartum hemorrhage, your postpartum hemorrhage, these are important topics. Antepartum hemorrhage meaning placenta previa and placental abruption. These are all important topics. Okay, then you have important topics in obstetrics, labor. Okay, then you have puerperium. These are important topics. Hypertensive disorders of pregnancy, important topics. All right, so all of this has been covered with you in great detail yesterday, right? Okay. All right, so my advice to you would be that you go through the videos which are there free on YouTube, the sessions that have been previously taken. Okay, so keep that in mind. We have time limitations. We can also okay, types of hysterectomy. All right, before I wrap up, let me talk about the type of hysterectomy. For Fatehpuria, he's asking me the types of hysterectomy. So if you look at the types of hysterectomy, okay, basic type of hysterectomy. Okay, if you remove just the uterus and the cervix, this is total hysterectomy. Total hysterectomy. Uterus plus cervix removed. Okay, when you remove the tubes and ovaries also, it is called hysterectomy plus bilateral salpingo-oophorectomy. It is called as hysterectomy plus bilateral salpingo-oophorectomy, right? Okay, that is called as hysterectomy plus bilateral salpingo-oophorectomy. Then the types of hysterectomy will depend upon the radicality of discussion. So there are radical hysterectomies. So we can have radical hysterectomies, like we are removing more and more tissue laterally. Okay, so that means we go radical. So when you have radical hysterectomy, okay, or you can have a simple hysterectomy, okay. Now simple hysterectomy is also called as type 1 hysterectomy or extrafacial hysterectomy, okay, where only the uterus and the cervix along with the covering fascia is removed. That is simple type 1 hysterectomy. Radical hysterectomy can be of two types depending again upon the radicality. We have type 2 and type 3. Type 2 is less radical, type 3 is more radical. Type 2 is modified radical, which is also called as Werdheim's hysterectomy. And type 3 is radical hysterectomy, also called as Meig's hysterectomy. And then we have other advanced types of hysterectomies like type 4 and type 5, which are basically pelvic exenteration surgeries. Okay, fine. So these are the different types of hysterectomies based on the radicality of the approach. The other way to describe hysterectomy is by the route the hysterectomy is performed. So you can have abdominal hysterectomy, you can have vaginal hysterectomy, and you can have a laparoscopic hysterectomy being performed. So there are different routes of doing a hysterectomy also. So that will depend on the different routes are going to be there. Then there can be abdominal, there can be vaginal route of surgery, or there can be a laparoscopic hysterectomy being done. Okay? All right. So with this, we are going to finish the session for today here. All right. If there are any further doubts, please put them on the chat box. I will take them. Last moment doubts here. Okay. Right. The notes will be provided to you on the notes will be provided to you on the Telegram channel of PW MedED. Okay. All right. Now Mohit wants to discuss twin pregnancy. Let me see if I have anything on twin pregnancy. Some diagrams if I have. Let me check so that we can have a quick revision of twin pregnancy. Let me check. Okay. All right. All right. So let's have a look. Let's have a look at twin pregnancy. This is twin pregnancy, monochorionic, dichorionic confusion in that. All right. So this is for your confusion. I actually had a image here. All right. Cool. So let's see quickly. Okay, Mohit? And for the rest of you are still watching. All right. So when you have twin pregnancy, okay, there can be dizygotic twin pregnancy or there can be monozygotic twin pregnancy. Okay, so dizygotic twin pregnancy means that they were separate to begin with. Okay, there were two separate zygotes. So both these separate zygotes will have their own separate placenta. See, they will have their own separate placentas, or they may have a single placenta, but they are separate. There is no connection between the placenta. And you can look here at the separation, the intertwin membrane. They will have intertwin membrane will have four layers. There will be amnion and amnion, right? And there will be two layers of chorion in between. Okay, so this is dichorionic, diamniotic. Okay, so your dizygotic type of twins are always going to be dichorionic, diamniotic. First of all, that is an important point. Okay, remember that. Then we have monozygotic twins. Now, monozygotic twins, they were a single zygote to begin with, and then they divided into two. So, depending upon the timing of their division, they can be dichorionic or they can be monochorionic. Okay, so among the monochorionic type of monozygotic twins are more common. So timing of division is also important. Okay, when you have monozygotic type of twins, right, then if the division takes place, division take place before 3 days of fertilization. Division takes place before 3 days of fertilization. It gives rise to dichorionic diamniotic type of twins. Then if the division takes place between 3 to 8 days of fertilization, it gives rise to monochorionic diamniotic. So you see there is a single placenta that is shared in between the two twins. And if you look at the intertwin membrane here, see there is going to be amnion, and there is going to be there is going to be no intervening chorion in between. Okay, there is going to be just amnion and amnion. Okay, so the intertwin membrane is only going to have two amnions in the intertwin membrane. Keep that in mind. This is monochorionic diamniotic. Okay, then if the division takes place between 8 days to 12 days of fertilization, between 8 days to 12 days of fertilization, it will give rise to monochorionic monoamniotic type of twin. So you see here there is a single fused placenta which is shared in between the two twins. The placenta is shared between the two twins and they are in the same amniotic cavity as well. This is monochorionic monoamniotic. So there is no intertwin membrane in between the two twins, right? So there is no separation partition between the two twins, monochorionic monoamniotic. And then the rarest type of twins, when the division takes place beyond 12 days of fertilization, if the division takes place, that is once the embryonic disc has already formed. Okay, then in that situation, what can happen? Then in that situation, it will give rise to monochorionic monoamniotic type of twins. Along with that, they will be conjoined. They will be joined together. So monochorionic monoamniotic conjoined twins they will give rise to. They're also called as Siamese twins, right? And they can be joined at various locations. At the head, craniopacus, craniopacus, at the hip bone, ischopacus, at the thorax, thoracopacus. They, first of all, they're extremely rare, but most commonly among them are also thoracopacus. All right, so this is about your Mohit, your doubt about your monochorionic and dichorionic. So remember this here, that overall the most common type of twin, if they ask you, is dichorionic diamniotic, because anyways dizygotic twins are more common and dizygotic twins are always dichorionic diamniotic. And the next question they ask you about superfecundation. This has been a NEET PG question 2 times, so I believe this has a very important potential for repeat. So superfecundation meaning fertilization of 2 separate ova in the same cycle but by 2 separate acts of coitus. Now, how is it different from any other type of twins? Now look at this. I'll give you an example for you to understand. The question that they had asked in NEET was that there is a couple in which the woman delivers twins, okay, and the father has a doubt that one baby is his and the other baby is not his. That is only possible in this circumstance when there is superfecundation. That means fertilization of 2 separate eggs in the same cycle but by 2 separate acts of coitus, not necessarily by the same or different partner. That doesn't matter. Okay, if they are by the same partner, there is no way of knowing also, and there is no problem also. The only clinical relevance of superfecundation is in paternity disputes, when those paternity disputes arise. Okay, and then another question they ask you is, what is the best for determination of chorionicity? So the best for determination of chorionicity is ultrasound. So the chorionicity that I just described to you can be seen on ultrasound. Look at this ultrasound. This is twin number 1, this is twin number 2 here, and we can see that they are in their own sacs. Okay, there is a thick intertwin membrane. Okay, and this is where the placenta is developing, and it is dipping here in between the to in between the intertwin membrane. So this is what we call as the twin peak sign or lambda sign. Okay, so a thick intertwin membrane is there, and we can see the chorion dipping in between the intertwin membrane here. Okay, so this is what is called as the twin peak sign. So twin peak sign is seen on ultrasound. Okay, this is seen in dichorionic diamniotic type of twins, and the best time to perform this ultrasound is before 14 weeks, anytime before 14 weeks, preferably between 10 to 14 weeks. Okay, now med psycho, what about superfetation? Superfetation is something that has not been superfetation is some, before I come to superfetation, let me complete this. On ultrasound, if we see a T sign meaning that there is going to be twin 1 and twin 2, and this is going to be the placenta, let's say. Okay, developing placenta, let's say, intertwin membrane, and there is no dipping of chorion in the intertwin membrane. This is the T sign. This is twin number 1, this is twin number 2 in their own sacs. Okay, placenta developing, and the placental tissue or the chorion is not there in between the intertwin membrane. This is the T sign, monochorionic diamniotic type of twins. That is T sign. Okay, now you're asking me, med psycho, what about superfetation? Superfetation is a situation which I remember as one fetus over the other fetus. Okay, so fertilization that happens in two separate cycles. Okay, fertilization that happens in two separate cycles, and you know, it's something that is difficult to understand, because it's something that is not naturally happening in natural pregnancy. It has not been documented in humans so far, right? So basically it is fertilization of two separate eggs in two separate menstrual cycles, meaning that one fertilization happened, one implantation happened. Okay, then after a month later another fertilization happened and another implantation happened, because there is a potential space there in the uterine cavity, that is the decidual space, up till about 14 to 16 weeks of gestation. So it is theoretically possible, but it has not been documented in humans for one very important reason, that by once pregnancy occurs, ovulation is suppressed na. Once a woman conceives, there is no ovulation happening, it is not suppressed, so there is absolutely no chance for a fertilization to take place. But in case it did happen, in case the ovulation is not suppressed, it is a theoretical possibility but has not been documented so in humans. Okay, so fertilization of two separate eggs in two different menstrual cycles is what is superfetation. Okay, med psycho, so it's a rare case, or what? It is something that it's theoretically possible, has not been documented in humans. Okay, so like that. Okay, so with this we finish off the discussion, right? And for those of you who are saying that some topics have been discussed, some topics have not been discussed, well, it's a huge subject. That is the limitation of the time that we have got. So what we chose to discuss is the most important aspects on which clinical questions are asked. Okay, because clinical aspects are something that need to be discussed, so the discussion catered to the questions which are more clinical oriented, and again those sections of obstetrics which have been asked in your most recent exams as well. Okay, fine. And if you really want to read up more about amenorrheas and puberty disorders and fibroids that have been discussed with great detail in the NEET PG segment discussion that was free on YouTube in this channel itself, so you can watch it there as well. Okay, so now I'd end the session for today. Thank you so much.